National Institutes of Health and Research is facing major funding cuts.
A rollback of $12 billion in public health funding
after the federal government abruptly pulled more than $100 million in funding.
Are we all here to defend science?
The politicization of public health is something that is also a key part of this anti-democratic project that we find ourselves in right now. So people might say, oh, well, why is public health being attacked? Why is science being attacked? This doesn't make any sense. We should want these things. Building up scientific capacity is always a good thing for countries, for communities. But the important thing to keep in mind is that this attack on science and specifically the scientific capacity of public health has been a bigger part of this project from the far right for a while.
You're listening to UAR Remixed, a podcast companion to the journal Urban Affairs Review. In this episode, part 2 of our mini-series with the authors of the recent journal Symposium, we're turning our attention to the intrinsically political nature of public health. You just heard from Charlie Willison, Symposium guest editor and assistant professor at Cornell University. Charlie, why do you think public health is inherently a political issue?
So why is public health a political issue? So we can say generally, right, that politics is a part of everything. I think some really key ways that you might be surprised to think about, well, why is public health specifically a political issue, are a couple of different things. So the field or the discipline of public health, I'm a professor in a public health department. Public health, and I will say with a big asterisk for our contemporary moment, but historically, public health and also today, as far as public health scholars, public health practitioners, is a discipline that is very much grounded in science and in empirics, and much of public health, and I don't mean this as a criticism, but sincerely believes that if we do the science, then the science translates directly into policy change, right? We know what works best. We test all of these different interventions, and then we make evidence-based recommendations. And then we know what to do. Now, we know, and this is what I teach my students in Introduction to Public Health Policy, is that gap between these evidence-based recommendations that we have and the policy outcomes that we get, that's where the politics happens. So just because we know what should be done, just because we might have an idea about the best course of action, obviously doesn't necessarily mean that that will happen in practice. And we can think about this in a lot of different ways. For example, maybe that policy won't get put on the political agenda. We know that lots of different public health issues, especially issues that affect marginalized and oppressed communities, heavily stigmatized issues. It takes a lot more to get attention for those issues. So how do you raise salience of these contentious or more politicized public health topics? And this is something that we've seen across history, right? And the attention to different types of issues also gets at other more embedded political issues about representation of different groups in political decision-making at different levels, and especially at the local level. So how much political power and representation do different groups at the community level have for their needs in their community? A great example of this is the Flint water crisis. Some of you might remember this from 2015 in Michigan. This was a primarily Black community, very low-income community in Michigan that had egregious levels of lead in the water for months. The water transition, basically getting people access to clean, non-toxic water, took about a year, maybe a little bit longer. And people might say, well, why? Like, how could this happen in the 21st century in the United States? And this was actually a deeply embedded political problem where the needs and voices of Black community members were specifically ignored by policymakers at the state and local level. And so this is just one example of how all these things work. Again, we think that there's a solution, but different parties will use power in different ways to further their own goals and can interact in adverse ways for the needs of community members on the ground.
In the last episode, I also spoke with Sarah Gollust and Nátalia de Paula Moreira, co-authors, along with Stephen Moore, Breeze Floyd, and Erica Franklin Fowler, of the article Racism as a Public Health Crisis: How Declarations Shape Local TV News Attention to Racism. Sarah, Nátalia, and their co-authors investigate the role of local media in drawing attention to racial disparities in public health through an analysis of what they call local declarations of racism. These declarations, however symbolic, play an important role in educating the public about the relationship between health outcomes and socioeconomic disadvantage. Sarah, you submitted this piece in 2024, before the last presidential election and before the massive, unprecedented changes we've started witnessing in the federal landscapes of public health. What lessons should we draw from this study, despite the retrenchment of reactionary politics and this anti-science sentiment?
Well, I think one of the kind of theoretical foundations of the paper and the study in general was thinking about how there's both direct and material effects of a policy, as well as the more indirect or symbolic effects of policy. From a more direct side, we could think of a public health entity or, county board passing a policy that provides like specific material resources that go to a community, like, building a road or, as I mentioned before, hiring someone who's responsible for health equity in that community. But what our study points out is that there's also these symbolic or communicative effects of a policy where the policy itself has an impact on how we understand an issue, how the media covers it, broader public understandings. And those symbolic effects, I think, are also really important. And so I think public health officials should carry that forward, thinking about both of those effects on politics, because essentially if a policy is passed that provides more resources to address a problem, that can change the political dynamics, but so too can raising awareness, reaching the media about an issue like racism. That can also change the political dynamics in ways that we can't necessarily predict, right? In both intended and unintended ways. So I think what our study demonstrates is that media attention to racism was a consequence of passage of these declarations, and that this might have shaped how the public feels about the link between public health and racism as a crisis, as well as the public attitudes and understanding of equity-related policies even today. So that's, I think, an important area for continued research, but also continued attention by public health officials.
Charlie, what about you? If you were to restart the symposium today, what would you want to think about or challenge? What new questions have the last few months generated for you?
So this is something that I have thought about a lot, and I spend a lot of time thinking about. I also spend a lot of time, or have spent a lot of time, talking to different groups, specifically healthcare and public health groups, about this. I would embed ideas about the relationship between democracy and public health in this call for papers specifically. So I talked a lot about power in the relationship between, or in why there's this strong relationship between public health and politics. Why does politics influence public health? Who gets their priorities met, and who does not? So this has always been a problem in the United States. Politics is something that cannot be separated from public health anywhere around the world. It's also worth noting, obviously, that the United States is a country that is founded on racialized hierarchies, and the design of cities, really the cities that we know today, is something that happened at a moment in time at the turn of the 20th century, when the preservation of these embedded racial hierarchies was something that was forefront. So when cities were being built, the distribution of these new public goods and services that have a disproportionate effect on public health, like, do you get water? Do you get access to sewage and electricity? Where are we putting schools? Again, for different groups of people, these power dynamics across race and class lines structured into how cities today were built. And so this is always the distribution of public health goods and services is something that has always been very politicized and has always had big implications for democracy. And again, when we're thinking about constraining representation or constraining the ability of different groups to participate in these decision-making processes that necessarily affect their access to key public health goods and services or key resources that affect their public health and well-being. Now, over the course of the 20th century, we saw a lot of movement to kind of get rid of or reform a lot of these entrenched power dynamics to improve representation, improve participatory engagement of race and class-based groups to improve their socioeconomic mobility and political participation, kind of level the playing field to improve equity. Now, when we think about the federal relationship, so even though we've always had these big problems of who gets access to what we haven't seen as much of are these big changes to or attempts to concentrate power in the federal government. So thinking about checks and accountability across the three branches of government, those types of things. And so what we're seeing today is obviously an unprecedented attack on the separation of powers that we have across the three branches of government, which has really big implications for democracy, but it also has really big implications for public health. And it has these implications for a variety of reasons. So I was talking about, and I have been talking a lot about public health and the concentration of public health goods at the local level. Now, we can think about public health goods at the local level. Where we get the money for public health goods at the local level kind of comes from two buckets. We can think of the buckets of social determinants of health. So things like, again, water, sanitation, schools, even policing. All of these things are broader factors that we know have this disproportionate influence on public health. Now, most of these services, again, from the inception of cities as we know them at the turn of the 20th century through to today, are mostly locally based. Sometimes you get state pass-through funding, but a lot of this money or these resources come from local tax dollars. Now, by contrast, when we look at the capacity or the money for public health services, when we think about traditional public health services, so things like vaccines, things like access to healthcare, all these kind of more traditional types of screening services for different disease categories that we think of as public health, even things like pandemic preparedness, right? All of those types of services are organized through local public health departments, and local public health departments receive money from the federal government and from states. And what we have seen in this consolidation of power through the federal government is also a stripping or a gutting of this really key public health capacity and spending. Now, what that means, there are a lot of big implications. But what that means is that we are almost certainly likely to see this change where the ability of local governments and states to provide these public health services will be in the same model as these key social determinants of health, right? So if you cut back a lot of the federal spending, local governments will have to make up that money themselves. We actually saw this happen during the COVID-19 pandemic when the federal government, the first Trump administration, did not use their emergency powers through the Stafford Act to allocate COVID-19 emergency funding for about 6 months. And that meant that states had to dip into their discretionary funding. They have balanced budget amendments. They can't take on debt. And so states were trying to do this themselves when they have been relying on this kind of shared budgetary model for a very long time. And that meant that in some cases, states had to make really tough decisions where they had to roll back COVID-19 policies early, for example, to open up restaurants to bring in more tax dollars so that they could spend on things like masks and other protective equipment before we had vaccines. So the implications of this broadly are really extreme when we think about rolling back capacity for key provision of public health goods and services. And to bring it back to my original point, this also has really substantial implications for democracy. So if, for example, when we think about the variation across different places, right? Some local jurisdictions have more money, some jurisdictions have less money, especially when we think about rural areas and things like that. When we roll back the provision of the federal funding for key public health goods and services, that means that inequality in the distribution of these goods and services will increase. And then that will obviously magnify existing inequities across different groups that have more or less access to political power in all these different ways that we've discussed.
Capacity is also at the center of Andrew Kelly and Dee Kuo's article, Building the Plane While Flying. I asked them about our political present and why a local framing is so vital, not only to understand public health policy, but to bolster it.
Our current present and the Trump administration kind of 2.0 and Robert F. Kennedy Jr. at HHS and what's happening to CDC in particular, my first inclination is to think that understanding state level and county level is that much more important if they're going to be left more on their own to try to address emerging public health crises. I think there was importance of relationships with CDC and county level governance during the early part of COVID, and which was during the first Trump administration. And there were, CDC officials coming out to Santa Clara County and working with Santa Clara County officials. Whether that would happen again, it's hard to know. So are those counties going to be even more on their own? I think that's right. And I think what that means is that they have to better understand how to build up capacity at the county level. And what we saw as helping capacity was partly the product of these relationships with local community-based organizations. And those partnerships between a county health officer or the Department of Public Health for a county and community-based organizations, whether it's like violence prevention organizations or other similar groups, those don't grow up out of nowhere, right? They're the product of earlier policy and earlier investment, right? So it's today's investments in public health are going to not only produce better outcomes today, but they're going to build up partnerships for the future that then will be able to be relied on when we have this larger emergency, which was really unprecedented for so many of these counties and all of these health officers. What came out in some of the interviews is that they were very much used to being part of the response, be it to emergencies, be it wildfires that we've dealt with in California, mudslides and flooding. That they're part of it, but the health officers in the Department of Public Health were never the ones that were leading that effort. They were in the more supportive role. And those episodes, those policy episodes, lasted for a short amount of time. Whereas here we're talking about a massive response with public health at the forefront that lasts multiple years. So I think when, I think public health is a really good window into kind of how federalism works and federalism and health policy in particular, and that constitutionally, historically, legally, a lot of that is left to the localities, whether it's the state and then the state delegates it to the counties. But that gets increasingly the case during this current administration, right? Particularly for states like California that want to keep on being kind of at the forefront and investing in public health. If that's what they want to do, it's going to be more on the state, which means they're going to have to invest and build this capacity. And I think our article gets at some of the relationships that should be the focus, as well as kind of how to do that. And it requires investments in policy today.
One case that I would point to in our article is the ABAHO, the Association of Bay Area Health Officers, which began in the 1980s during the AIDS/HIV crisis, when the federal government was completely absent or, in denial, not supporting. And that's when a set of health officers formed a collaboration across, I think, 11 counties, stretching from Sacramento down to the Bay. And they worked with hospitals, universities, social, civic organizations to address this crisis. They collected data. They did all of the things that one would do in a public health crisis. And that relationship lasted. They have informal and formal mechanisms that link them over time. So they, handled swine flu and avian flu epidemics together. They created an Ebola response, SARS, MERS, all these things over time. Andrew is completely right that there is a little bit of a template we've unwittingly laid out, like we didn't mean to, but there are all these different collaborations that we identify as being important, and they can be sustained over time, particularly when you know that the federal government is not going to help you. A lot of these different institutions are under attack. So for them to collaborate and work collectively on shared goals and to align whatever resources they have is more critical now than ever.
One thing to quickly add on, I think it's an even harder question to answer now than it was in January of 2025 in terms of how this plays out. Because I think there are a lot of kind of checks or mechanisms within the federal system that we would have believed would have protected the state and counties in their ability to implement policy and follow, the needs of the locality. But I think what we've seen is there's increasing comfort from the current administration with ignoring judicial decisions or going against longstanding relationships and trying to create constraints that we would previously not have imagined would have been placed on counties. Many people thought, like they can't do anything about like vaccine requirements at schools. That's a local level decision. It's hard to know what's going to happen. So what constraints this administration might try to place on a public health response, even by a California county, I think it's a little bit unpredictable. But I think that what's still clear is that the counties and the localities are going to, at least in the near term, are going to be way more responsible for investing in and building up their own public health capacity. And the outcome is going to be the next time around, or the next time this type of capacity needs to get mobilized, what that means in California, what that means nationally, is probably even greater levels of inequality in outcomes and responses, as it's left even more to the states and localities.
Even when you have state capacity, there's always this gap in implementation. Kathleen Sullivan and Patricia Strach look at the importance of political power in public health policy implementation in historical perspective by looking at trash collection.
Well, one of the things that comes through is that sanitation serves public health, and it is a public good, and we foreground that. But our study also shows that achieving public health or pursuing public health requires power. It requires government power to operate, even for benign purposes. And we identify power in a few different ways in this article. So one thing that we find is that sanitarians actually had to push out some other interests. So for example, scavengers had been collecting garbage for decades in these cities, but they were competing with professionals. And so we find that using the idea of sanitation, using the idea of cleanliness, and then connotations of filth of scavengers themselves and the work they did, that professional sanitarians pushed out scavengers. But we look at that in this project to see how that was almost required of public health officials to utilize the power of the state or the local government in this case to determine who's an appropriate collector. We finished writing our book during the height of the COVID pandemic, and we saw a lot of what we were writing about going on in society in the 21st century. And I think one thing we thought about is that even when government is acting in the public good, it's going to utilize authority and power. And sometimes I think when I looked at reactions to public health measures during the pandemic, people felt that. They felt the government using power. But that doesn't mean that government's illegitimate when it's using power. Governments need to use power and authority. And sometimes they're done benignly, sometimes they are done in a discriminatory way. But we want to pay attention to that. Public health is not non-political, but we don't want to talk about politics and power as if it's a bad thing. That's what governing is. And you're able to see it when you look at these seemingly mundane practices.
When we were working on the book and we're working on the article, everything about public health is political. So one thing when the cities are instituting these garbage collection programs, people don't want to participate. Like we think now, of course, you take your can out, but they don't want to buy a can. They don't want to put it out on the street. They don't want to clean it, and they don't want to bring it back. They don't want to change the behavior in their houses. They're used to doing things in a particular way. And so when we were looking at this, it was very interesting because the time period that we're looking at, everything about public health is political. Everything is deeply political. And the resistance to these measures kind of brought down mayoral administrations in some places. Like they kicked them out because people were so upset about having to do things that we take for granted. So our perspective is probably different than a lot of other people's in the fact that, I think, maybe we were lulled, like a lot of people, into thinking public health had become more apolitical, right, over time. And so the period that we were studying doesn't really look like the period that we were living in, 5 years ago, for example. But I think what it does is it shows you that the ultimate political act is convincing people that something isn't political. And so that goes back to this idea that, yes, public health is political, and yes, it invokes power, but that's not necessarily a bad thing, because the goal of, can you imagine if we had no garbage collection programs now? Can you imagine if we went back to the world that these people were living in? Cities were really awful places at that time. And so when we think about, yes, public health does use the power of government, it does kind of put costs on particular people. It is very political, but I think in the end, a lot of the goals of public health are things that we would all agree make our lives collectively better.
And another thing that the kind of current time makes us think about is state building and dismantling of the state. And believe it or not, garbage collection is not major state building, but imagine, as Patty says, a world without garbage collection. And you see it when garbage collectors go on strike. Suddenly people are aware that garbage had been picked up, and that was a government that was making that happen. And so it's a very close local lesson in the ways that the state is invisible to many people. And as we're dismantling our federal administration, it might not be immediately visible what those agencies have been doing, but soon it will be. And I think garbage collection provides a more immediate, smelly kind of example of that.
Now, if you recall from our last episode, the local doesn't have a neatly defined geography. Maybe we think about it with proximity or a region or just the legal boundaries of a town, city, municipality, or county. But infectious diseases, air pollution, and other environmental factors don't respect these artificial boundaries. Some issues might prompt the creation of new geographic areas to manage or address them, like a special district. We talked to Holly Jarman about this. She and her team studied mosquito control special districts in Florida, perhaps a niche issue to residents outside the coastal South, but one that we should start considering more seriously as climate change begins to recalibrate where and when mosquito season is. Creating these special districts wasn't without controversy, though, even for a problem as universally reviled as the mosquito.
So one of the things we tried to construct by this paper was a political history of how did mosquito control evolve within the state of Florida. And one of the things that we discovered is that the push to create these special independent districts was a political choice. And it was a political choice, particularly in areas where there was rapid economic development, or people were attempting to rapidly develop the area, build housing, attract migrants to that place. And so the push for special districts allowed supporters of economic development to kind of create coalitions of support amongst actors that might otherwise really disagree. And that support led to the establishment of independent districts with the sole goal of mosquito control in some parts of the state, whereas in other places, mosquito control didn't happen until quite a bit later, and was part of local government in general in the area. So mosquito control started as this important part of developers' plans to build communities in areas where they were investing. And so they tended to congregate in areas where there was capital investment, over time, some degree of wealth. Whereas special districts were the least successful and survived the least in areas with poorer populations, maybe areas with marginalized populations, or where people were just sparse. So you end up with history driving development of special districts in certain places and not others. And what we see today is that special districts still survive. They're far fewer in number because they haven't all survived, but they remain primarily located in wealthier areas with property values that are higher. Compared to county mosquito control programs, they gather and they expend more dedicated resources because they have the ability to raise their own taxes. They have limited service areas that tend to be organized around certain neighborhoods, so they do exclude some people. And this local service delivery really does matter because of the decline over time in state level funding for mosquito control. So the ability of each of these programs to raise funds is based on local wealth, particularly property wealth.
And Holly, I mentioned climate change a few minutes ago. What is the scale of this now for public health researchers?
So climate change is really important for vector-borne disease. As climates get warmer, as they change, you can find species there that were not really prevalent before. And this is a big problem for the United States because what's predicted to happen is that climate change will change where we find mosquitoes bearing dangerous diseases. And today we find them in Florida. We're finding mosquitoes in Florida that were not present some years ago, and they're spreading diseases that were not commonly spread in Florida some time ago. But we're finding them now in Florida. The prediction is with further climate change, we can start finding more of those mosquitoes spreading those diseases further north. So it's a huge problem for the ability of public health capacity to meet the need of where we will find these kinds of diseases. Because we have really effective things we can do to try and prevent the spread of disease, but they require sustained investment. So in public health, we can't just turn up when we found the disease. We have to be investing constantly. We have to be conducting surveillance. Public health services like mosquito control, but not only limited to that. Public health services require lots of data collection. They require local activity. They require investment because the personnel need to have specialized training, and they need to be consistently invested in, because if we stop monitoring for disease and then suddenly it becomes a news story, we're probably acting too late. And a lot of public health capacity suffers from this stop-start because we see an alarm, we see a problem, we worry that something is actually happening, and we invest money in trying to address the problem. But then when the disease stops spreading, or the patterns of spread change in such a way people get used to this being a problem, people change their minds about the importance of the problem politically, then you see resources stop being channeled into public health. I think we're seeing that now with the debates that we see nationally as well as locally around public health capacity. The proposals currently for funding public health are really alarming. The leaked proposals that came out of HHS recently includes a lot of cuts to what I would consider to be essential public health programs. So politically, with my political science hat on, I can see this cycle happening again of public opinion has turned away from public health, and we're seeing now resulting cuts in the kinds of investments that are required to really maintain services. What I worry is that that will affect prevention in the future.
How do you think politics shapes public health? In terms of planning, governing, distribution, all of the steps we've been outlining across the symposium.
So I'm a political scientist, and my tendency is to think that everything is political. But I would say that public health is inherently political. A lot of the services that we are thinking about when we talk about public health directly affect people, and some of them directly affect themselves, their families, their communities in some important and sometimes intimate ways, right? Some of our public health interventions like vaccines affect your body directly. So people's interest in public health is very personal. It's very much to do with who they are as people. It's very much to do with how they relate to medicine and science, how they relate to government, how much they may trust government. And there are many good reasons for people to have lost or not had enough trust in government. And so to me, public health is political for those reasons. Public health interventions are mostly delivered by governments. They are proven by science to be effective, but public health governments have had a mixed history of being respectful of people's rights, respectful of their bodily integrity. And so it's reasonable that people have lots of questions about how governments will deliver public health services. The importance of public health to me is because it's collective. It's about trying to protect not only yourself or not only deliver services for the individual, but to try to protect a community. I think that's why it's so important. And when you have a situation where people are feeling more like they need to be protected as individuals and not feeling that sense of community, and also not feeling that sense of connection with government or the nation, it's not surprising really that there's political criticisms of public health.
The politicization of public health is something that is also a key part of this anti-democratic project that we find ourselves in right now. So people might say, oh, well, why is public health being attacked? Why is science being attacked? This doesn't make any sense. We should want these things. Building up scientific capacity is always a good thing for countries, for communities. But the important thing to keep in mind is that this attack on science, and specifically the scientific capacity of public health, has been a bigger part of this project from the far right for a while. So if you read Project 2025, some of their specific goals that they outlined was actually heavily cutting back the capacity of the Centers for Disease Control and Prevention, limiting different types of reporting. But something that's really notable is that they actually wanted to separate the Centers for Disease Control and Prevention into two branches, where one was just data and with no interpretation. And the other one was specifically to limit the policymaking recommendations that the CDC could put forward. So constraining their ability to make science-backed decision-making, but specifically constraining their ability to translate any of that into policy action. And so again, we might think about, oh, well, why would you want to do this? Authoritarian regimes around the world, when they are attempting to consolidate power, one of the first things that they go after are universities, right? Universities are centers of discourse. They are hubs for lots of different ideas from lots of different groups of people. And if you are attempting to consolidate power, that's a key threat to your project, right? Because plurality is a threat to concentration of power, is a threat to authoritarianism. Universities and science, all the science that comes out of universities is a form of plurality that is a key threat to this broader project. And public health is just one piece of that. And so this narrowing of public health, this politicization of public health, cutting back public health capacity, again, is a great way to maintain power. It's also a great way to demobilize community if you're taking away goods and services that help people increase socioeconomic mobility. This is something that we have seen throughout the history of the United States, done as a way to maintain oppression of different groups across race and class lines over centuries. So again, this is nothing new, but the way that we are seeing this across the three branches of government at the federal level is what is so new.
My thanks to Nátalia de Paula Moreira, Sarah Gollust, Andrew Kelly, Didi Kuo, Holly German, Patricia Strach, Kathleen Sullivan, and Charlie Willison for joining us for this series. You've been listening to UAR Remixed, a podcast by Urban Affairs Review. Special thanks to Drexel University and the editors at UAR. Music is by Blue Dot Sessions. This show was mixed and produced by Aidan McLaughlin and written and produced by me, Emily Holloway. You can find us on Blue Sky at urbanaffairsreview.bluesky.social for updates on the journal and the show. Please rate, review, and subscribe on Apple, Spotify, or wherever you get your podcasts.